Welcome to Deer Haven Gardens, the first women's alcohol treatment facility to offer the Sinclair method in a residential setting. The Sinclair method, integrated with evidence-based therapies, treats the whole person, getting to the source of the behavior so cravings diminish, drinking decreases, and a lack of interest in alcohol is developed. Our luxurious and very private 6-bed facility allows our team to provide highly personalized care in a serene and peaceful setting in the Blue Ridge Mountains of Asheville, North Carolina. We understand that recovery is not one size fits all, which is why our dedicated team tailors each treatment plan so that clients not only recover, but discover a new way of life. Start living your new life now at Deer Haven Gardens.
Welcome back, everybody. Once again, I am Jenny Williamson, the Executive Director of the C3 Foundation. On behalf of myself and our founder and CEO, Claudia Christian, we are glad you're watching our second annual virtual TSM conference, Stronger Than Your Drink. Please feel free to use the chat function if you're watching live on Twitch to ask questions all throughout the panel. This conference is available to view and participate in for free, thanks to our two co-headline sponsors, RIA Health, Work It Health, and our panel sponsor, Deer Haven Gardens. If you would like to support the work of the C3 Foundation, there is a donation link in our profile, and we also have a timer that drops a donation link into the chat during the broadcast. And if you're on Twitter, please feel free to keep live tweeting our conference with the hashtags Stronger Than Your Drink and Options Save Lives. It's a great way to amplify the impact of our conference. Next up, we have Dr. John Umhau presenting Taking a Holistic Approach to AUD Treatment with TSM. Dr. Umhau is a medical director of alcoholrecoverymedicine.com, where he provides addiction medicine consultation through telemedicine. For over 20 years, Dr. Umhau was a senior clinical investigator at the National Institute on Alcohol Abuse and Alcoholism of the National Institutes of Health, and has authored more than 50 scientific publications. As a former commander in the United States Public Health Service, he also served in the Indian Health Service and the FDA. Dr. Umhau completed a residency in clinical preventative medicine at Johns Hopkins and is board certified in both addiction medicine and preventative medicine. He received a bachelor's degree from Davidson College, a medical degree from Wake Forest, an MPH from Johns Hopkins University, and is a certified physician executive. This panel was recorded in advance due to a last-minute scheduling conflict.
My brother went to a funeral last week. His friend's son had died. He was just 36. I think he died from alcoholism. This should never happen. When I was doing my medical training at Johns Hopkins, I learned all I could about helping people with alcohol problems. But I actually learned more from studying alcoholism and alcohol abuse at the National Institutes of Health for 20 years. And today I want to share with you what I learned there, and also what I've learned in my practice of telemedicine. And I want to share with you what I tell my patients who come to me for help. And I'll be following this outline. We know that the critical thing about recovery from alcoholism is to have a clear mind. But nutrition is really important for this. And I'll talk about some of the things that can be done in your diet to make your mind clear. Next, I'll talk about the importance of reducing the craving for alcohol, which we can do today with medicines that we didn't have years ago. And finally, I'll talk about the importance of living in a culture that promotes healthy drinking or not drinking at all. First, let's talk about clearing the mind. Well, first thing I want to talk about is how complicated alcohol use disorder is. There are many reasons to drink. There's social reasons. There's drinking because alcohol relieves suffering, as can be seen here by this prescription pad for medicinal alcohol. But once alcohol consumption becomes excessive, addiction can develop. And what happens in that case is that people can use the Sinclair method. And as everybody knows, the Sinclair method has one important caveat. You have to take the naltrexone an hour before you drink every single time. But as you can see from this slide from Dr. Sinclair, which shows how alcohol craving is almost eliminated after 110 days of treatment. You can also see that although almost 200 people started in this study, only 75 finished. This always makes me concerned that people who have the best intentions of reducing their alcohol may not finish, may not be able to follow through, may not have a clear enough mind to be able to take the naltrexone as they want to. And this is in part because the alcohol is damaging the brain. We all know that alcohol kills brain cells, but I just wanted you to see this MRI of the brain. On the one side, you can see the lighter colored brain, and on the right side, you can see more dark areas, which show where the brain has atrophied or become smaller. What happens in this case is that particularly the white matter connections in the brain have deteriorated. And this permits the brain mechanisms that normally prevent us from becoming addicted from deteriorating. The frontal cortex is where we have our willpower, our executive functions of our mind come from this part of the brain, which is really important for controlling our emotions and also our alcohol craving. These emotions and alcohol craving can be subconscious, but when the frontal lobe is degraded, we can't control them as well. The lower brain stem circuits are unchecked. The emotions are poorly regulated and alcohol addiction develops. But fortunately, the brain can recover. One study showed that 6 weeks after alcohol detox, the brain volume increases by 2%, but especially the white matter connecting different parts of the brain. Again, these white matter nerve fibers allow the executive function or willpower from the frontal cortex to overcome the addictive craving in the lower brain and brainstem. But for this recovery to happen, it's critical to have a good diet. It's really important to take all of these nutrients when you're trying to recover from years of alcohol consumption. Because when you're drinking heavy, you don't eat the same amount of food, and the food is where we get our normal nutrients. People with alcohol problems are typically deficient in B vitamins, particularly vitamin B1, which can cause Wernicke's encephalopathy if you don't get an extra amount when you stop drinking. Another important vitamin is the folate of tetrahydrofolate. This is a really critical vitamin for some people with alcohol use disorder who have a enzyme deficiency in the enzyme that takes folate, which is fairly common in supplements, and makes it into more bioavailable type of folic acid, which is used for all kinds of processes, including making more serotonin and other neurotransmitters. Omega-3 fats, as some people would say, is probably the most critical part of recovery. Probiotics can be important, as well as zinc, vitamin D, vitamin C, magnesium, and calcium. I want to especially talk about vitamin D because vitamin D is a common deficiency many places. And if you're deficient in vitamin D, it's very likely that you have excessive inflammation. I wrote an article earlier this year describing the critical issue for people who get COVID-19 and are deficient in vitamin D. Don't be deficient in vitamin D. You can take extra vitamin D, or you can get your vitamin D levels checked by your physician. And many times the multiple vitamins that people take don't provide nearly enough vitamin D to prevent deficiency. We certainly don't get enough vitamin D in our food. We get most of our vitamin D if we're out in the sun, but most of us are spending our days indoors on computers, and we don't spend as much time in the sun that would allow us to get plenty of vitamin D. It's very important for preventing depression as well. Well, the important part about nutrition is that it can promote inflammation, and inflammation can really be a critical part of the neurodegeneration, the dead brain that occurs with heavy drinking. This inflammation is triggered by a number of things. It can be triggered by endotoxin or inflammatory mediator chemicals called cytokines. Inflammation can be triggered by poisons, by pain, by heavy metals, by infection. And these activated microglia, or the brain immune cells, which are triggered by all these factors, can actually kill other neurons because of their action to fight infection. And once those neurons are killed, the brain is deteriorated, and those dead neurons cause a lot of debris in the brain, and then that activates even more microglia. Importantly, this inflammation prevents brain regrowth. And a lot of us think that when you have inflammation in the brain, it's the cause of many mental illnesses, including alcoholism. The cycle that I see is this. This is sort of an example of how a lot of us think alcoholism affects the body. First, with heavy drinking, the alcohol alters the gut microbiome, the normal gut bacteria in our intestines. And this causes a leaky gut and bacterial debris called endotoxin to leak into circulation. This endotoxin is just one of the many chemicals in the bacteria in our gut. And when it is in excessive amounts in our bloodstream, it can cause liver inflammation, liver disease, and stimulate the production of inflammatory cytokines so that the liver can eventually become fibrotic and eventually cirrhotic. These inflammatory cytokines, these cell mediators that can cause inflammation signals throughout the body, can get into the brain. And in the brain, as we've seen, we can get cell death and brain cell degeneration, but we can also get symptoms of just brain fog or depression, or maybe loss of control. Maybe people lose their temper. Maybe they can't control their urges to drink as much. In any case, this brain fog can sometimes be relieved by a drink of alcohol. And then that starts a cycle again, because people want to feel better, and the alcohol can make things feel better just briefly. But with time, increased drinking makes the problem worse. Here's some experimental evidence just to prove, although it's kind of complicated to see this slide, what I want to make the point is that with just 19 days of abstinence, the leaky gut gets better, there's less endotoxin in the bloodstream, there's less inflammation, and that causes less craving, less depression, and less anxiety. And I really invite you to take a look at some of the references on my slides if you have any doubt at all that this is not just a really critical thing in alcohol use disorder. Sort of simplifies it to look at this slide here, because on the one side we see the gut microbiome and the unhealthy microbiome that has excess endotoxin, this cell debris that leaks across the gut wall into the bloodstream. A lot of things that cause this problem. Antibiotics can alter the healthy microbiome and kill a lot of the healthy bacteria. And processed food can promote unhealthy microbiome, as well as not having fiber in your diet. Excess omega-6 fat can promote inflammation in the gut wall. Excess alcohol can make the gut wall more permeable, more leaky, so that you get more endotoxin in the bloodstream. And then there's the toxins in our environment, in our diet. Sometimes people think gluten or artificial sweeteners, or even other drugs can cause a leakiness in our gut membrane. And all this endotoxin in our bloodstream can promote inflammation, not only in our liver, but also in our brain and other places in our body. If you drink coffee, it's sometimes better. Sometimes we say it's a good idea to switch drinking high fructose corn syrup sodas with coffee, which has been shown to reduce the gut permeability. But fortunately, eating healthy can really reduce endotoxin. There's a study done that showed that just 4 weeks of a healthy diet, with fish and lots of fruits and vegetables, can reduce the endotoxin activity in the bloodstream. So there's lots that you can do to eat better. Another thing that you can do is to take prebiotics, which is non-digestible fiber, or probiotics, which are live microorganisms like people would get in fermented foods such as yogurt. Or you can perhaps get the particular probiotic, a bacteria called Lactobacillus GG, which can actually be promoting liver healing. And it may also reduce craving for alcohol, although there's no good studies about that yet. One of my friends who does research suggests that might be the case. But we do know that reducing liver inflammation by your diet can really have a great impact on your health of your liver. Next, I want to talk about something that I think is probably the most profound effect on my patients, and that's increasing the amount of omega-3 fat and reducing the amount of omega-6 fat. Like vitamins, these are essential in our diet. They can't be interconverted. Omega-6, which is abundant in our diet, can't be converted to omega-3. And they both become critical parts of our body and our brain cell membranes. They're both active in a lot of metabolic processes and can be turned into similar molecules, but those molecules have very different effects on inflammation. Omega-3 fat is really limited in our diet today. We can get it from seafood, we can get it from leafy plants and from mother's milk. Omega-6, on the other hand, is very abundant. It's very inexpensive to grow soy, corn, peanuts, and this is what's been put into vegetable oil. It's also what's used to fatten beef cattle and hogs and chicken, so that the meat from these animals today has a high percentage of omega-6 fat. And this diagram just shows that Americans now consume an excessive omega-6 fat. This is from soybean oil. You can see that in 1900, there was very little soybean oil consumed, whereas in the year 2000, there was about 25 pounds of soybean oil per person per year consumed in the United States. This is a huge effect because this stays in the body. This doesn't get digested. It becomes who we are. Now, this slide is a bit complicated, but bear with me because it's important. And I wouldn't show it to you if I didn't think it would help you understand why it's so important not to eat excessive amount of omega-6s. And that is because the omega-6 here on the left in aqua, in the purple, show that they're metabolized to become the longer arachidonic acid, the longer chain molecules that cause inflammation. The omega-6 are abundant in all these corn and soy and safflower oils, but they are acted upon by these enzymes that elongate the molecules. And you can see, if you look carefully, that this molecule here, this omega-6, is very similar to the omega-3, except for these little lines here, which show that there are extra double bonds here. And that's what makes this an omega-3. These omega-3 fats are also 18 carbons long, just like the omega-6 fats here that we get in our diet. But because there's so few of these omega-3 fats compared to the omega-6 fats, we can't make enough of the long chain omega-3s, EPA and DHA, which are critical for inflammation and for our brain function. The omega-3 fats are present, as we mentioned, in things like leafy plants or walnuts. And when you have these products from these omega-3s and omega-6s, they form different molecules, which are called prostaglandins, and they have a very different effect on inflammation. This slide here kind of shows what's going on. Here comes a neurotransmitter, and it's going to act on this cheap protein coupled receptor. On the left here, you see the American diet with the red omega-6 present in the membranes. This is supposed to be a cell membrane. On the right-hand side here, you see the omega-3 abundance of the Japanese diet with plenty of aqua omega-3s. And you can see how this membrane in the, say, the nerve cell is going to act differently in the omega-3 rich membrane. It cleaves off these omega-6s, which cause increased inflammation. And this is where aspirin and things like ibuprofen work. On the other hand, when the aqua omega-3s are released on the right-hand side, we have less inflammation. And of course, all this affects gene expression. Well, if this is important, then we'd expect those who eat seafood have less mental problems. And the mental disorder that seems to be most problematic for my patients is bipolar disorder. And you can see here that patients in Iceland and Korea and Taiwan that have a lot of omega-3 in their diet from eating a lot of fish, they have very little bipolar disorder compared to places like Hungary and Germany and New Zealand, which don't eat very much fish. And this is repeated in studies of looking at depression and bipolar depression and even postpartum depression. There's lots of data from placebo-controlled double-blind studies showing that omega-3s also help mental health. In this study here, which is a pretty profound study of bipolar disorder, high-dose omega-3 fatty acids can help people with severely affected by bipolar disorder recover. And over here on the left, you can see that this is the cumulative survival. This is start off with 100% of patients here, and over the 3 months, 120 days in the study, patients were given either placebo or omega-3 fish oil. And you can see by the drop off here in the red placebo line that people given the placebo, they didn't survive out of the hospital. About 60% of the people in the placebo group had to go back to the hospital, whereas only a couple of people in the omega-3 group had to go back to the hospital. And this study was so profound that the Harvard study committee who was reviewing this study realized that the study couldn't continue for the full year, but they had to stop the study early because they felt it wasn't ethical not to continue to give everyone omega-3 who participated in the study. They didn't think that it was ethical to give placebos to people with bipolar disorder, that everyone should get omega-3 fatty acid. Unfortunately, for a lot of political reasons, this study has not been well appreciated, but it's very important to understand for people that have problems controlling their emotions. And there are also quite a lot of studies showing that omega-3 supplements help antidepressants work better. And I just wanted to mention that there is what they call a meta-analysis of 11 studies, and synthesizing the results of all these studies shows that omega-3s are really critical for mental health. It's important to remember that you become what you eat. The half-life of the omega-3s that you eat and that's stored in your body is actually about 2.5 years. This journal, the Journal of Lipid Research, published my study, and I got a cover story about it. It's my 5 minutes of fame because I did the PET scans that measured the amount of the omega-3 fatty DHA that was taken up by the brain. What I found in my research through these PET scans was that people with alcohol use disorder need more omega-3. Their brains took up more omega-3s than normal people do. That makes me think that it really is critical. And although we don't have the best studies today that demonstrate, that prove that people with alcohol use disorder will recover quicker with using high-dose omega-3s. That's the experience of my patients. I've had seems like almost all my patients seem to do better on omega-3s. Sometimes they just lose their craving. Sometimes they just think better. Sometimes it allows them to just remember to take the naltrexone before they drink. So this is probably the most important advice I can give people is to eat really well, to take lots of omega-3s to help your brain recover, to think clearly. I had one patient who felt like her brain just cleared suddenly when she started taking the omega-3. She no longer had an irritating feeling that had been previously only relieved by drinking alcohol. Now she could think clearly enough to always remember to take the naltrexone and get into the recovery program that she had done before that she knew could really help her. So that's probably the most important thing that I can tell my patients who come to see me, and that's the most important thing that I would like to leave you with. The next, I'd like to talk about how to cut the craving with medications. We know there are a lot of medications that can treat alcohol use disorder. There's 3 that are approved by the FDA. disulfiram, which has been used to cause an adverse reaction in people. People who take disulfiram would get sick if they drink alcohol after taking it. This is the only medicine that we had to use to treat alcoholism a number of years ago. But fortunately, the FDA has approved a number of other medicines. Acamprosate, which is really great for people who have stopped drinking and want to be helped with sobriety. And also naltrexone, both in the long-lasting injection form and the pills, which are commonly used for the Sinclair method. In addition to those medications which have been officially approved by the FDA, there are a number of medicines that the doctors are aware of that can treat alcohol use disorder. And some of them may be more effective. Topiramate, baclofen, ondansetron, prazosin, varenicline, and others can really be very helpful for people with alcohol use disorder, stopping the craving. And these medicines also all tend to reduce the craving if they're taken over time. And this graph just gives you the idea that over 3 months, even if you're not drinking and not following a Sinclair method, taking these medications can really help reduce the craving. And they're really recommended for people trying to be abstinent. It's important to remember that brain opioids really drive behavior. These endorphins, or opioids in the brain, they're neurotransmitters, and they're released with pleasure to reinforce that behavior. They're particularly released with social activities. And these endorphins are released also when drinking or by just thinking about drinking. They're released when you crave alcohol. And these endorphins are released the very most when you have your first sip of alcohol after being off alcohol for a while. And that's important to remember. And the Sinclair method takes advantage of that fact by targeting the naltrexone right before that first drink. It has to be used an hour before that drink so that the blood level of naltrexone is sufficient to provide a naltrexone wall to block the craving and the pleasure from that drink. Because if alcohol's reinforcing effect to stimulate opiate receptors, it's always blocked with naltrexone. Over time, drinking behavior can be extinguished. But if it's not used every day, on the alcohol-free days where there's no naltrexone in the bloodstream, the opiate receptors become supersensitized, and healthy endorphin-producing behaviors can be reinforced and can eventually rewire the brain, as Dr. Sinclair used to like to say, and they can replace the craving for alcohol. Some possible benefits of the Sinclair method are that alcohol craving may be permanently eliminated. It's also beneficial because the endorphins are blocked only when people take naltrexone. If you're not going to drink, you don't need to take naltrexone. It's also important to consider how this is attracting people to get treated who are not ready to be abstinent. Maybe they just can't imagine life without alcohol, yet they know they might have a problem with drinking heavy. So if they take the pill beforehand, they can still drink and they can be engaged in treatment. And this can lead them to get help if they should ever need it. It's also a patient-centered kind of treatment. And that's the way that doctors are thinking about helping patients these days, not being the paternalistic boss of someone's health, but guiding them, being their partner in their health. When you take Sinclair method use of naltrexone, you get fewer effects than when you take naltrexone daily. And you also can reduce alcohol gradually. So you reduce the risk of delirium tremens. And you can also reduce the need for costly inpatient detox. And the pain of detox can be avoided. In some ways, I think that detox and the pain of withdrawal in the hospital is sort of a barbaric way to take care of the problem, when we know that the people that follow the Sinclair method can oftentimes, not always, but oftentimes can gradually reduce their consumption and eliminate the need for the inpatient detox. The other benefit of naltrexone is it's inherently less expensive than other forms of treatment. And it's even applicable for use in the developing countries. However, there's some downside of the Sinclair method. One is that patients can feel that their drinking is sanctioned by their doctors, and they can drink when they could otherwise stop drinking. Also, if people are inconsistent or non-compliant in their use of naltrexone, they might drink more. I had a patient one time who took naltrexone faithfully Monday through Friday, but one Saturday he wanted to just enjoy his birthday. So he didn't take the naltrexone for a couple of days and then went out with his buddy to the bar. And he came back and he told me, his doc, I drank 40 drinks. I've never had that much alcohol before on one time in my life. It tasted so wonderful. And of course, what had happened was that the lack of naltrexone for those few days beforehand had upregulated or allowed the opiate receptors to be upregulated. And so they could sense the endorphin pleasure of the drinking even more profoundly. And the drinks tasted even better. And my patient, therefore, drank more than he would have otherwise. Naltrexone may also delay someone from seeking psychosocial support. If someone's highly anxious, maybe that's the kind of care that they need. Naltrexone may also impair coordination if someone's drinking and driving at the same time. And it sometimes can give people false confidence that drinking is safe. The safest way to go forward with alcoholism is to stop drinking. And when a patient comes to see me, I understand they may not want to stop drinking, but I always remind them that drinking is optional and that the safest choice that they can make is to stop drinking entirely. The medication-only treatment also has another potential downside, that is it can reduce the potential for personal growth that I've really seen in people who are following the 12 steps, who are really working a recovery program, or working on trying to make themselves better human beings. And that's one thing that I oftentimes wonder about. Well, why does the Sinclair method fail? Well, I've seen the Sinclair method fail in a number of patients. And particularly it occurs when people drink too long or drink too fast, and they can overcome what I think of as a naltrexone wall that blocks the pleasure from drinking. Sometimes life events crush the spirit and eliminate the desire for recovery. People just have no more reason to live. And sometimes, as I mentioned before, people that use naltrexone sometimes and not other times may actually end up drinking more. Another problem with the Sinclair method is people may forget or run out of their naltrexone. Sometimes they lose their prescription and they're not successful. There's also social pressure to keep drinking. Maybe people don't want to change their social lives. Maybe they want to keep with their same friends that are drinking alcohol. Maybe they have a nostalgia for the pleasure of drinking. Or maybe they're just emotionally suffering. Maybe they have depression that will be slightly relieved by drinking. Or maybe they just fail to work a recovery program. So there are lots of things that can make the Sinclair method fail. And what's really important to remember is that if someone can reach extinction of the desire to drink through diligent use of the Sinclair method over months and days, then that is a real blessing, because not everybody can overcome craving. But once you've overcome craving, you get the choice to be able to stop drinking. And that's really important. Not everybody can get to that point. And when you can get to that point, I always recommend people to stop drinking, to work a recovery program, to find people around them to help them stop drinking, because there's really no data that shows that people can safely do the Sinclair method twice. I have a number of patients who were completely successful at overcoming the desire to drink. It went for weeks and weeks without drinking anything. And of course, to start with, they would remember to take the pill and drink, and they wouldn't drink excessively. But after some years, they forgot the pill or thought they had recovered without the naltrexone, and they went back to heavy drinking. And a number of those patients have really suffered tremendously from subsequent alcoholism and although it's possible they could recover from their alcoholism with medications in the future, it's really hard. So for people that are successful with the Sinclair method, I really recommend that they take their recovery that they've accomplished seriously and do everything they can to make sure that they stop drinking, because that's the safest. One reason why people fail with the naltrexone is because even though they take the naltrexone, they don't have enough naltrex in their bloodstream to be successful. Here you can see a graphical depiction of the naltrexone level. Here the black is the naltrexone level at time 0. It's maximal an hour later, and that's when the first drink happens. But over time, you can see that the naltrexone level goes down. And in about 4 hours, it may not be effective. Some people, it may be effective as long as 8 hours later, but certainly after a number of hours, the naltrexone is no longer effective. I had one patient who relapsed because although she took the naltrexone an hour before she went to drink at a wedding, she took the naltrexone at noon, and after the wedding, they had some drinks about 1 o'clock. And the afternoon was more socializing. In the evening, there was a dinner with wine, and after the dinner, there was drinking and more champagne. And late at night, and by 11 or 12 o'clock at night, she was drinking champagne, and then there was no naltrexone in her bloodstream to block the endorphins from the champagne. And the next day, she didn't think at all about naltrexone. She just started drinking again, and that was how she relapsed. So it's really critical to remember that the naltrexone pill, although it's amazing, it's not magic. And you have to consider the blood levels of naltrexone. Sometimes people are given higher doses of naltrexone by their doctor. Sometimes they're told to redose. And it's all very individual on the patient's particular situation. Unfortunately, though, once you take your first drink, the subsequent endorphins released by naltrexone are not quite so strong, and they can be blocked by lesser levels of naltrexone in the blood. And even here, after the time has elapsed quite a bit, there is the possibility that a lower level of naltrexone in the blood will block the craving for alcohol. Because when you think about alcohol and drinking alcohol, you release endorphins, just like it is when you actually have a drink. The next medicine I want to talk about is a camprosate. A camprosate helps those people who want to stop drinking. If you're not drinking and you want to stay abstinent, a camprosate is your first go-to drug. It reduces the persistent symptoms which accompany abstinence, such as insomnia, anxiety, and restlessness, and can reduce craving. It's important to know that a camprosate doesn't affect the liver, so it's useful if someone has liver inflammation, which can be a problem for people who take naltrexone. It also has side effects that can be considered like any other medicine. Diarrhea, nausea can be one, gout or depression or edema. I didn't mention some of the side effects of naltrexone, but naltrexone can also affect the liver. It can also cause depression and rarely suicidal ideation, which is an important reason not to take naltrexone. Naltrexone is of course not effective in everyone. Sometimes it makes people too anxious. Sometimes it has other adverse effects on sleep or on the GI system. So naltrexone can't be used for everyone. Another medicine that's really helpful is toprimate. Even though it's used off-label, that is that the FDA hasn't recommended it particularly, doctors still prescribe it to reduce alcohol craving. And there's excellent evidence that toprimate can reduce the desire to drink and the number of drinks per day. Patients describe this as somehow they feel full when they drink and they just don't want any as much. And some studies suggest that it may work more strongly than the naltrexone. One of the things that is interesting about about toprimate is that the dose should be gradually increased over many weeks. Side effects include difficulty concentrating, tingling, taste perversions. Sometimes people get anorexia or even nausea, but particularly memory problems. Eye pain or glaucoma is another serious problem. But sometimes intoxication is exaggerated, particularly if people drink heavily after taking the toprimate. And toprimate should be discontinued slowly. It's important to remember how toprimate works. Again, it's remarkable, but it's not magic. Once you take the toprimate, the peak level is about 2 hours later, and it goes down. But then you take your next dose, and the toprimate level goes up again. And when it goes up again, it never comes down to the same dose until after about 5 days. The dose stabilizes. That's why you may need a week at each dose adjustment to make sure that you're okay with your body's okay with that level of toprimate. It's also important to note that there may be different effects on craving right after you take the naltrexone, just as there are different effects on craving right after you take the toprimate, just as there are different effects on craving right after you take the naltrexone. Another drug which is really helpful is ondansetron. Ondansetron works rapidly to reduce the amount of daily drinking in some people. These are the 30% of the people with the genetics for alcohol use disorder or signs of alcohol use disorder before age 25. It doesn't work for the others. And rarely, it might make some people drink more. It can cause headaches sometimes, and it can cause the peak concentration is reached in about 2 hours, and it's given twice daily. Ondansetron is unique in that although it's used at a high dose for nausea, it's used at a tiny dose for alcohol use disorder, only usually about a quarter of a milliliter. And I'm showing here how some patients take it using a very tiny syringe, and they use the pediatric liquid formulation. And this is only about 5 drops of this pediatric dose. And sometimes people use a compounded pill that's made by a special pharmacy. When starting, the dose is increased slowly. Sometimes a lower dose works better than a higher dose. Ondansetron can interact with antidepressants that increase serotonin, and side effects are sometimes rare and include a headache, as I mentioned before. Another drug that's really interesting and very helpful for some people is baclofen. Baclofen has a very fascinating story. It began with a very prominent physician named Oliver Edmondson, who was a brilliant cardiologist, and he developed severe alcoholism. And he tried everything that he could to stop drinking. And eventually, in desperation, he kind of took his treatment into his own hands. He thought that the suppression of the craving might suppress the disease altogether, since addiction is really sort of a symptom-driven disease. And he experimented on himself using baclofen, which is a muscle relaxer. It's been around for a long time. And it had been shown that this baclofen could reduce addiction in animals. And Dr. Amundsen increased the dose until he reached a level that left him free of any craving for alcohol. He wrote a book about it, and this book called The End of My Addiction, or Heal Thyself, was really quite a sensation in France, and almost 300,000 people in France have used baclofen to try to drink less. The research that was done subsequent to his book shows that baclofen can reduce craving and the drinks per day, especially in people that are anxious. But like all these medicines, it doesn't work for everyone. And studies have shown mixed results. It's important to use sometimes because it can reduce withdrawal symptoms. It's also safer for patients with liver damage. The dose has not really been established, so it's important to work with a knowledgeable physician about this. The dose is oftentimes increased gradually, and it can cause side effects, which are very, very common to get these side effects, but they'll generally go away if the dose is reduced or the increase is slowed down a little bit. And to discontinue, baclofen must be tapered slowly to avoid seizures. Next, I'm going to talk about the importance of creating a culture that will promote recovery. So everybody knows that one of the important things for recovery is exercise. Exercise, particularly 30 minutes of moderate exercise 3 days a week, has been shown to improve immune function, to reduce the excessive inflammation, and it can reduce the risk of illness. So this moderate exercise is sort of defined as by an increase of pulse rate by 70% at the age maximum heart rate. For instance, that you take your age in years and subtract it by from 220 and multiply it by 3/4 to get the dose. Next, I'll show you the psychosocial stress leads to chronic inflammation, but the emotion from helping others protects and reduces inflammation. The genes that regulate inflammation have been measured and show that the happiness that comes from purpose-driven work and purpose-driven happiness gives a message to reduce inflammation, whereas pleasure-driven self-gratification does not have the same beneficial effect on the inflammatory response. And some behaviors have been shown to release opioids. Dr. Sinclair talked about the importance of doing these behaviors to increase opioid release when you're not drinking, so that the addiction to alcohol can be replaced by healthy activities. These include exercise and sex, interacting with dogs, sunlight, or eating, but also social activities like laughing together, synchronized dancing with other people, social cooperation, group singing, and Christian religious rituals. These have all been shown to increase endorphin levels. And what's really fascinating about this research is that people that do the same activities, but not in synchrony, not together with some other people, they don't get the endorphin release. The behaviors have to be done with other people to get the beneficial endorphin release. This is really important as you plan for your recovery. Dancing, being involved in a choir, these kinds of things can be really important for long-term recovery. And of course, when you think about Alcoholics Anonymous incorporates a lot of these activities. Alcoholics Anonymous may work in a number of ways. It increases motivation for recovery. It helps psychological well-being. And it may work through some of these methods that we just saw that increase endorphins. And Alcoholics Anonymous, whether you feel like it works for you or not, the data shows that it does promote abstinence better than other psychosocial treatments that it's been compared to. On the right-hand side, you can see the results of meta-analysis. The dark green studies are statistically favoring Alcoholics Anonymous, and the light green trend toward favoring Alcoholics Anonymous. And the red dot shows the one study that favors non-Alcoholics Anonymous treatment. Finding a group that fits you can be really critical. There are groups that support abstinence. Alcoholics Anonymous is the most prominent one. And of course, there's groups that support the Sinclair method, online forums, Embody Daily, and also groups like Medication Assisted Recovery Anonymous. Line Rock groups and Celebrate Recovery also support TSM, although they're not as well known. TSM is not as well known. This just shows that there is a plan for using the Sinclair method in the rest of recovery. And if anyone has any questions, I'd be glad to answer those questions sent by email to me here at my medical practice. And if you do have any questions, you can see me in my medical practice. I'll be glad to talk to you. Thank you very much.
Sorry about that. I had my microphone on mute. So thank you very much, John. I appreciate your time. I've got a couple of questions, and I'm going to try to keep them brief because of time. So you had a slide about ways that the Sinclair method fails, and you talk about when people give up or when they intentionally push through the effects of the medication and things like non-compliance. In your medical opinion, are these really a failure of the Sinclair method saying that it's not working? Or is this more a situation where it just simply may not be the right treatment for that individual at that time?
So what's required is to heal the brain, to heal the mind, and that can happen through good nutrition. In my clinical experience, people that follow my nutritional recommendations can all of a sudden start using the naltrexone faithfully. I had a patient last month, and she came to me because naltrexone worked great for her, but sometimes she'd go out with her boyfriend and wouldn't take the naltrexone. She just wanted to get blitzed. And she came to see me. I tried another medication with her, and a week later she came back and said, that other medication didn't work, doc. But the fish oil, the omega-3s, it just took away my craving. Not only that, saw the week later, and she just had gone out again with her boyfriend. And this time she took the naltrexone faithfully. She was just starting to take it every time she drank. And about a week later, she just decided she didn't want to hang out with a boyfriend that drank. And so she probably is not drinking anymore at all now. But it was the nutrition that allowed the Sinclair method to work. And I didn't have to really stop the naltrexone. She just needed to do what I suggested for her nutritional stuff.
Additional support.
Yeah, but it's specific things that the nutritional aspects can be critical for the brain function work, for the white matter tracks to connect the willpower to the subconscious.
And you also mentioned something about people who may have a slip on the Sinclair method because of things like running out of their prescription or the potential for needing to redose. And what would you say to doctors, to your peers, about how to handle having the possibility of early prescription refills for people who may be redosing at the beginning of the process?
Well, that's a good question. It's important to follow up patients well, because naltrexone can cause depression. So we want to make sure that our patients are doing well on naltrexone before we refill it. And it's on an individual basis. And certainly patients lose their prescriptions. And that's a really sad reason for somebody to relapse to alcoholism. But and so it has to be sort of individualized. I'd like to be available to my patients so that if they get into trouble with this, I can call in a prescription for them. It's sort of the individualized aspect of treatment that's important, I think.
And you mentioned quite correctly that there are people who will succeed with the Sinclair method and then maybe get complacent or reach a point where they believe that they no longer need it and then start drinking without it. What's your process to drive home the point that addiction can be relearned if you continue to drink and do not take the naltrexone ahead of time?
Well, what's my process to help people is to just hammer home the point that the culture of their world has to change. If they only take away the pleasure of drinking and do nothing else, it's not going to be successful. People can't get endorphins from binging on Netflix. It doesn't work. You need to get endorphins from the healthy activities that have been proven to show an increase in brain endorphins. Those are the ones that we know from tradition work, and we know now from science kind of why they work, because they increase endorphins. And I sort of have to explain it that way. And I also just talk about the bigger picture of alcoholism treatment. And I talk about the people that I know that have failed the Sinclair method because they didn't have a recovery program. They didn't have a community around them. They didn't maintain gratefulness. And people can do that through all kinds of ways. They can do it through their religious groups. They can do it through the TSM groups. They can do it through just their friends and family. But they have to create a non-drinking culture. If they continue to have the same peer group, they're not going to be successful. If they don't maintain gratefulness, they may not remember how nice it is to be able to think clearly and to get up the next morning after not drinking and not have a hangover. And I just have to remind people to have a good memory about that. One thing I've started doing is to encourage my patients to make a movie of themselves that they make for themselves, describing to the camera how glad they are that they're going to stop drinking, and how bad they felt when they were drinking, and how grateful they are that they're not drinking to excess. So they can help remind themselves how good it is that they're not drinking. Sometimes people write journal articles to themselves or make notes to themselves, just describing how they felt when they were drinking, so they would remember why they feel so glad that they've stopped drinking.
And then two final questions that I'm asking to everyone. One, in the number of patients that you have treated with the Sinclair method, what is your approximate success rate that you've seen in your patients?
Well, it's hard to say. When I first started this practice, I counted my patients, and it was about the 70 or 80% that everybody else gets with the Sinclair method. Now I think it's probably better than that because I've started doing more aggressive nutritional therapy, but I haven't measured it exactly.
And then, final question. The theme of this year's conference is Stronger Than Your Drink. How does the Sinclair method make your patients stronger than their drink?
Well, the most oppressive feature of alcohol use disorder is the incredible craving that people are faced with. People don't want to think about alcohol, and it's really hard for people to put it out of their minds sometimes. And the naltrexone allows them the freedom to get out of that craving.
Thank you very much, and we appreciate you being part of our conference.
Thank you very much.
You're welcome.
My pleasure. My pleasure.